Should I start?
Yes, please.
Assalamu alaikum wa rahmatullahi wa barakatuh. Today I'm giving this case presentation about post-parathyroidectomy struggles. This is a brief history of our patient. He's 34 years old male patient from Mansoura. He's single, non-smoker. 2014, he had an attack of malignant hypertension that led to right eye blindness. And since then, his serum creatinine was discovered to be high. Gradually progressed to end-stage renal disease at 2016 and accordingly started regular hemodialysis. Regarding his CKD-MBD profile on regular follow-up, he had a mild infrequent heel pain. Intact PTH was persistently high above 2000 picogram per ml, high alkaline phosphatase also, and there's a calcium level 9.5, phosphorus 7.5, and 25 hydroxyvitamin D level. The CT scan showed osteoporosis, and all medical trials, including Sinacalcet, failed to control his condition. Neck ultrasound and system EV scan showed diffuse parathyroid glands enlargement. 2 years ago, the patient was referred to have parathyroidectomy, which was unfortunately total parathyroidectomy. After the surgery, our patient had severe hypoparathyroidism. Always intact PTH is below 9 picogram per ml. He also had severe symptomatic hypocalcemia in spite of maximum doses of oral calcium, active and inactive vitamin D. He was dependent on IV calcium, reaching 5 gram calcium gluconate twice weekly on dialysis, failed to correct the hypocalcemia, but decreased the frequency of muscle pain and cramps. Thus, we started Forteo, which is teriparatide, in dose of 20 microgram per day, as a trial for damping the hypocalcemia and preserve his bone. 8 months later, the patient stopped teriparatide on his own, unfortunately. So this is the serial follow-up of our patient, starting with the symptoms. Started before the surgery by mild heel pain, after the surgery, a recurrent severe muscle spasm and lower limb weakness that partially improved after teriparatide and recurred again with high severity after stopping the treatment. The intact PTH was high and then always low. Also, the serum calcium always low. Phosphorus was like the following: 7.5 first, then these values. Alkaline phosphatase was first high, then also low, indicating a dynamic bone disease. And DEXA scan showed osteoporosis. So this time for discussion. What's your opinion?
Fine. Do you want me to start?
Please.
Fine. To start with, this is a classic case of hypoparathyroidism due to inadvertent surgery. We turn the patient from hypoparathyroidism to dynamic bone disease. Number one. Number two, why we haven't prevented this patient to reach this stage in the first place? Why we have waited till his PTH becomes sky high above 2000? There is obvious as well that his phosphorus was 7.4. Something wrong. Either dialysis was not quite right, inadequate, or he was not taking phosphate chelating agent, because this could be contributing to the hypoparathyroidism. Number one. Number two, have we any surgeons here on the call, or just all of us? I'm the only surgeon around.
I think you're the only great physician around.
Fine. So the treatment is basically not wrong with the operation, but with the technique, because it has to be subtotal or total with auto-transplantation. Because a dynamic bone disease is a disease with mortality, is a disease with increased fracture risk. And whatever calcium you give, it wouldn't be in the bone, it would precipitate in the heart valves, cardiac tissues, every known and unknown tissues in the body, rather than in the bone, because PTH does not exist. So we need at least to keep PTH, above hundreds, and it's recommended to 150 to 400 mark. This could prevent, to some extent, not absolute, but to some extent, dynamic bone disease. So the point is prevention, better than cure, as Professor Am mentioned early on, number one. Number two, we should work with the surgeon and educate the surgeon that dynamic bone disease is as dangerous as hyperparathyroidism, because it's killer as well. We don't, in Egypt, we don't have the resources for teriparatide. So we stopped the teriparatide for financial reasons, of course. And the treatment, either autotransplantation if we have some parathyroid glands left, or allotransplantation, which is all our case reports, and none of them lasted more than 2 or 3 years, and requires immunosuppression as well. So the treatment is not ideal and not always successful.
Agree, 100%.
But
so by the way,
the operation, the surgery is indicated, but it has to be subtotal or total with autotransplantation.
right.
So if you allow me,
we have to preserve some parathyroid tissues. We'll do our best. We're not always successful, by the way. With autotransplantation, because you autotransplant, you don't know, are you transplanting parathyroid tissues or transplanting fibrous tissues or area of calcification and hemorrhage, but an attempt to preserve some of the parathyroid tissues should be done.
You allowed me?
My nephrology colleagues, we shouldn't see this picture. We don't see here in the UK, I'm sure in the States as well. Patients climbing up with PTH 2000 and then thinking of what should we do? We should prevent this from happening in the first place. And will you explain the high phosphorus as well? So there's compliance issues or dialysis issue or some issues.
Right.
if you allow me, Dr. Ahmed.
Okay, Mahmoud, go on.
You hear me well?
I'm sorry?
Do you hear me well?
Yes, I do. Go ahead.
Okay. Regarding the surgery, when we asked the patient why did they remove all the parathyroid tissue, unfortunately they told him that it's a malignant disease and we are afraid it may spread, so we have to remove it all. That's why they removed it all, which is wrong, of course.
Did they do pathology? Was it malignant?
No, at all.
That's very, very unusual to be malignant, by the way. So I don't know how did they think it's malignant? It's very, very unlikely.
This was the explanation.
I think you just want to make him feel better, but I don't think this is a right scientific explanation.
Another false explanation. Why did our patient stop the teriparatide? Before stopping, he had a thrombosed AV fistula. His vascular surgeon told him that the teriparatide may be related to the thrombosis of this fistula. We searched this topic thoroughly and we found no evidence for that.
So you want to accuse the surgeons? You don't know anything?
No, I'm not accusing them. So
Dr. Halawa, you are mute if you want to answer that.
I'm just I have a few take-home messages from this case. Yeah, I agree with Dr. Halawa.
We haven't finished. Just wait. We didn't discuss. We are just started. Okay, we still have 15 minutes, I think, on our agenda, or at least 10. Okay. So first of all, I agree with Dr. Halawa that prevention is better than cure, and we shouldn't wait till the PTH goes up to 2000. By this stage, the gland is having a monoclonal proliferation of the parathyroid tissue and cells. So it starts with polyclonal proliferation, and if you don't control it, there is severe downregulation of vitamin D receptor and calcium sensing receptors. Even if you give a lot of calcium mimetics or vitamin D analogs to suppress the BTH or to control this patient medically at this stage, he wouldn't respond because the vitamin D receptor and the calcium sensing receptor in the parathyroid gland are down regulated, and there is a change from polyclonal to monoclonal proliferation. It's unresponsive, so it's too late at this stage. And I agree that this patient and at this stage will need parathyroidectomy, no doubt. But we should avoid this from happening. That's number one. Number two, when our patient reaches this stage for any reason, maybe he is non-compliant, not adherent to treatment, maybe it's not our fault, maybe it's his fault. So, or maybe he cannot afford the Senecalcet at the beginning or something, anyway, now we are by the end of the tunnel. Then we send the patient for a surgeon. You need to talk to the surgeon. You need to tell the surgeon our recommendation and guideline that was just discussed by Dr. Iman Nagy. We need BTH between 2 to 9 folds of the upper limit of normal. We need to keep the BTH at least 150, maybe to 300 or 400. That's good for us. Don't take out the whole parathyroid tissue and leave us with a BTH of 5 or 10 or 2 digits. At least it has to be 150. They do turbo BTH. The turbo BTH, they do intraoperative BTH, and they can measure the BTH. BTH is very short acting, so they can do it after 10 minutes of removing, say, 3 glands or 3.5 glands, and they just try to keep the BTH at least 150 to 300 or so. Some surgeons, they just are afraid and scared from the surgery failure, so they are more radical, more aggressive. We need to tell them that they need to be gentle. So that's not their problem alone, but it's also our problem. We need to communicate. Don't send the patient for parathyroidectomy, then the patient will come with hypopara, and you have to struggle and you have to fight with this problem, probably much more than the high turnover bone disease or hyperpara at the beginning. Now, the patient can be, admitted with several episodes of seizures, tetany, because of hypocalcemia. And if he or she is non-compliant because they were not taking their medication prior to the surgery, after the surgery, even if you give calcium and vitamin D and they are not non-compliant, you are not expecting them to take it. So they will come in again with hypocalcemic manifestation. You remember BTH function is to keep the calcium in the blood. If you don't have BTH, the BTH is 5 or 10, whatever you give, mega doses of calcium and mega dose of vitamin D, the calcium is not going to stay in the blood. The calcium is going actually to mobilize to the tissue and increase the chances of cardiovascular calcification. The next point is don't target normal calcium level. Just target the lowest calcium level that keeps the patient asymptomatic. So if the calcium is 7 or 8 with no symptoms or minimal symptoms, that's fine. Because whatever you give with the calcium supplements or vitamin D is not going to normalize the serum calcium without having BTH. So the message is try to be gentle, not expect the serum calcium to normalize after the surgery with this extensive parathyroidectomy. As Dr. Halawa said, doing parathyroid tissue transplantation doesn't work all the time. So even if the patient has total parathyroidectomy with implants of some of the parathyroid tissue in the forearm, it doesn't mean success in all the cases. This is very, very frequent problem. This is not the first case that Mahmoud is presenting. We are facing this problem all the time. Hypopara and hypocalcemia after parathyroidectomy is very, very common. I would say it's more common in Egypt, maybe because there is no dialogue or conversation with the surgeon, and they don't know our guidelines and our target level. But it's also not uncommon, even in America, to see the patient with hypopara after the surgery, because it's just the trend for the surgeon. He's scared to leave the patient with a lot of parathyroid tissue. Dr. Halawa.
Yes, definitely. And, Mahmoud himself, he presented a year ago a similar case, and we agreed that we need to discuss with the surgeons. It looks like the surgeons live on different planets. So we need actually a dialogue with the surgeons, explaining to them that a dynamic bone disease is a lethal disease as well. The quality of life of this patient is nearly zero, because he will be coming forward and backward with intravenous calcium, and and whatever dose you give, it will make him worse, because it could be precipitating in the cardiac tissues, everything, everywhere, not in the bone. So we render him worse. We made him worse. So I think we need to have a talk with the surgeons. We need to educate the surgeons about the CKD-MBD. It's not only just parathyroid out. It's more than that.
Correct. One more thing here. This patient is on dialysis, and we know that our dialysate calcium is high. So it might replace the calcium or improve the problem a little bit. What about if this patient is a transplant candidate? By the way, your urinary calcium handling, the kidney handle most of the absorbed calcium from the gut. We excrete about, if you absorb about 250, in the normal circumstances, 250 milligram of calcium in the gut, the kidney handle at least 150 milligram excreted in the urine. So if the patient has a kidney failure, he or she doesn't excrete this calcium. Okay, so the calcium, the kidney failure itself will help to maintain higher calcium, and dialysate will help. What if this patient is getting a kidney transplant? Now we know that kidney transplant polyuria happen, and now there is loss of calcium in the urine, and the patient is not on dialysis, not getting calcium. So the problem of hypocalcemia and hypoparathyroidism will be more manifest, or we would anticipate that this will be more manifest after kidney transplantation. This guy is young fellow, so he has good chance of getting kidney transplant. We have to be very careful after kidney transplant to replace his calcium. I was saying a question in the chat. I think Dr. Naga Abdelhadi mentioned if this patient could be a candidate for allogenic parathyroid tissue transplantation. And I will let Dr. Halawa and Mahmoud, who did a literature review about that, to answer this question.
Actually, yes, this is the right answer, which is at the time of transplant from the same donor, you can take one parathyroid and transplant this parathyroid into the arm. So this is the only solution, unless you give him teriparatide for life.
What about giving parathyroid tissue that was preserved from a patient who had parathyroidectomy in the past?
Look, do you mean cryopreserved?
Right.
Cryopreserved, we tried in Mansoura cryopreserved in 2 cases. None of them worked. Mainly because it was a year down the line. So the cryopreservation will lose the viability after some times, is a fraction of time. So let's just be realistic and forget about cryopreserved, because it does not exist in Egypt. Who has liquid nitrogen in his lab? Mansoura only. So basically, cryopreserve practically is not an option, just in the book.
Okay, very good. Thank you for the clarification. Dr. Mahmoud Sobh, can you summarize the take-home message and tell us your literature review about doing allo parathyroid tissue transplantation.
Yes. So our take-home message from this case and discussion: total parathyroidectomy has to be avoided, and the best way to avoid is by early treatment of secondary hyperparathyroidism, as late interference, as you said, may end by tertiary hyperpara and failed medical treatment. Second message is that sometimes, even if the surgeon is planning for subtotal parathyroidectomy, the residual tissue he is leaving behind might consist of non-functioning fibrous tissue. It's difficult to choose which part is viable and which is fibrous. Turbo PTH, as you said, Dr. Amr, intraoperatively may solve this dilemma. Even after even after adding teriparatide to the treatment in this patient, serum calcium did not normalize. Maybe this category of patients can be left with the minimal tolerated serum calcium, as giving mega doses of calcium to a patient with adynamic bone disease is fueling the process of extraskeletal calcification. As we remember from the calcium homeostasis, all calcium ingested through the gut may mostly either pass through the bone or excreted through the kidney. In our patient who is receiving mega doses of oral and IV calcium and vitamin D without passing any drop of urine, so no calcium loss in urine, and adynamic bone disease, no calcium pass to the bone, all of this mega dose of calcium will pass to cardiovascular calcification. Knowing that our patient is being prepared for kidney transplantation, this may raise a few questions. One, these doses of IV and oral calcium was trapped in his body by the state of aneurysm. So after transplantation, as you said, Dr. Am, calcium will be able to exit through the urine in the absence of the parathyroid hormone that stimulates calcium reabsorption from the renal tubule. No PTH to reabsorb the calcium. So this will lead to severe hypocalcemia, as in this case, who had iatrogenic parathyroidectomy after surgery for thyroid disease, who was hospital dependent for 3.5 years for the severe hypocalcemia, and her problem was not resolved until parathyroid allotransplantation. But what about this allotransplantation? It's all the literature present in the form of case reports, not randomized controlled trials. So in this review, prospective trials is warranted, especially to solve this problem. As Dr. Halawa said, the life is very poor life quality for this patient, even though replacement with teriparatide or other parathyroid replacement may be restricted by the cost and concerns related to development of osteosarcoma in animal studies. Another review of case studies showed heterogeneous results, although they were also excluding cases of CKD, dealing only with cases after thyroidectomy, related also to heterogeneous results, as there's a heterogeneous protocols. Some gave immune suppression and some did not give, with different regimens and protocols. So well-designed long-term controlled trials are needed. What about our patient CKD? We have two case reports for allotransplantation of cryopreserved parathyroid tissue for severe hypocalcemia in renal transplant recipient. The story of this patient started in 2003, where when he got his first kidney transplant after chronic glomerulonephritis. 2006, he had subtotal parathyroidectomy for tertiary hyperpara, and again it recurred later, the hyperpara. In 2009, after the recurrence of the hyperpara, he removed the remaining PTH parathyroid tissue and partially reimplanted into his right deltoid. Just a month later, he received a second kidney transplantation, and just 2 weeks after this kidney transplantation, as we said, all the calcium escaped through the urine and readmitted for severe tetany. 2 months later, he received his first parathyroid allotransplantation from a repository of stored cryopreserved parathyroid tissue. 3 months later, the parathyroid level went down again and received a second parathyroid allotransplantation that was done, and he was followed up until 11 months, and it was functioning. This report from 2010. Here is another one, more recent one, where they followed their patient for 2 years, and they reported well functioning, but as you mentioned, Dr. Halawa, all these reports of success means there's a lot of unreported failure. So in our patient with end-stage renal disease after kidney transplant, leaving him with this low PTH level, this state of hypercalciuria might affect the graft. What's the efficacy of such a treatment? Where to get his parathyroid tissue from? Either same donor or other patient who is candidate for parathyroidectomy. What's the perfect timing for this procedure? Can the transplanted parathyroid stimulate rejection? More evidence is needed to answer a lot of more questions. Unfortunately, most available data are just case reports. Thank you.
Very good. Mahmoud, just a quick question for you. Did you have a chance to see if anyone received the parathyroid tissue from the same donor with the kidney at the same time?
No. Both of the reports I mentioned was not from the same donor. Either cryopreserved or another donor who had CKD and had to do parathyroidectomy for CKD-MBD.
Thank you so much for explaining.
Yeah, actually, Mahmoud, there are a few case reports as well, reporting that kidney transplantation and parathyroid taken from the same donor. Yeah, but just case reports. We will never have a controlled trial or randomized trial here. It's all about case reports, if you're lucky.
Unfortunately.
Thank you, Dr. Halawa.
And don't forget, actually, as well, case report, there is publication bias here. They reported the successful cases. How many cases failed? You will never know. They will never get published.
Exactly.
Failure will never get published.
Yeah.
Exactly.
We'll hide it.
Very good. I think we will stop by here for this case. Thank you, Mahmoud, for your excellent presentation and literature review. I know that you have more knowledge and you want to share it, but we don't have time. Then we are moving to meet the experts. So I will ask Dr. Ghada El-Qanishi first, if she can unmute herself and give us good news that we received from the ISN today. Then we'll move to a 15-20-minute session for answering questions and sharing experiences. We have a lot of experts, so we need to learn from all of them. I would let it up to Mohamed Mamdouh if somebody wants to talk, and if you can unmute somebody if he raises his hand to discuss his question or his concerns. We'll start with Dr. Ghada El-Qanishi to give the good news.
Okay, thank you, Dr. Amr. It is a great pleasure really to announce a good news that we have received just 1 hour ago. We have just received that we have been upgraded. The ISN sistership has been upgraded to level B. This is a very great success for our unit. And I want to thank Professor Amr for his support throughout the previous 2 years from the start of this sistership sponsored by the ISN. And I hope that we can do our best during the next 2 years so we can be upgraded for level A, inshallah. Thank you, Dr. Amr, for your support and your help as a supporting center. And we hope the best for our unit, and thank you again.
Absolutely. What is the chances that we received the announcement and congratulations at the same time of our meeting? That's very nice. So we have been working together, University of Mansoura and University of Kentucky, for 2 years, and we were level C. Now we are upgraded and promoted to level B. This would be for the next 2 years, 2022 and 2023. Then inshallah will apply to be upgraded to the level A, the best level. So it's 6 years program, and I think we achieved a lot because the collaboration together and a lot of activities and a lot of things to learn and to teach and to share. I think in the next couple of years, please feel free, everyone, if you have any ideas to share or for any contribution in the future, to let us know. And I would like to thank all the contributors. There is a lot of people behind the scene. You cannot see. They contributed, you know, and they just dedicated their time and effort to make this happen and to make our sistership program successful. I wouldn't say names. Probably Allah knows the names, and everyone will get rewarded. And I thank everyone for his or her contribution.
Thank you, Dr. Amr.
Sure. And now I think we'll open the session for to ask the expert, and I'll let Mamdouh to coordinate this session.
So I think we have Dr. Ala, we have Dr. Halawa.
If you have just a question, just to mention it, and without, you know, mentioning the names, whoever has the knowledge or the experience can share the experience with us.
So we have some question in the chat, but I think maybe Mahmoud answered some of them. There is a question if we can save some parathyroid tissue after operation for transplantation. Is it possible?
I will let Dr. Halawa to answer this question. Dr. Halawa?
I think Dr. Halawa left.
Okay, I think my answer, yes, you can. As Dr. Halawa mentioned, and he's expert in this, it doesn't mean that this parathyroid tissue will function. The cryoprecipitation of this tissue, the preserved gland and cells goes down with time. So if you keep it cryopreserved for a week, it will be much better than if you leave it and cryopreserve it for a year, because the cells will die. Whatever you do, it will die with time. So time is essence here. So you have to do it, you know, quickly, and to coordinate that to get the patient, you know, to have parathyroidectomy, then transplantation in a week or two. It might be difficult, but it can happen. But yeah, the take-home message, yes, this can happen. Chances is low. Chances is lower with time. So don't depend on this parathyroid tissue. But in case if there is viability of the tissue, yeah, you can implant it.
Could we summarize, Dr. Amr, what type of investigation, if a patient has chronic renal failure or end-stage renal disease, what type of investigation we should to do to follow up his bone mineral disease? And either we know that calcium, phosphorus, parathormone, but other investigation, what we can do to differentiate.
Right. So on a monthly basis, we should get the same routine labs that Dr. Mustafa said: calcium, phosphorus, BTH. I would add to that also magnesium. Magnesium looks like an important, forgotten, unseen element and the mineral that we don't focus on. It's very essential. It prevent or decrease the cardiovascular calcification. Actually adding more magnesium to the patient, especially increasing dialysate magnesium, will help to suppress or slow down the calcification process. It prevents the calcium protein particle from being soluble to being insoluble and to crystallize in the blood vessel. Then if the patient, so I would add to this the DEXA scan every year or two, depending on the bone loss that you expect and the osteoporosis risk. So if the patient has high risk of osteoporosis, you need to do DEXA scan and to treat osteoporosis accordingly. Bone turnover biomarker, if you're not certain if the patient has high or low turnover bone disease, in the gray zone, again, say the BTH is between 200 to 400. So we wouldn't know if there is osteoporosis, high or low turnover bone disease. So I would recommend doing at least total alkaline phosphatase. If you can get bone-specific alkaline phosphatase or TRAP5B to tell you some idea about the bone formation and bone resorption rate. And again, if you cannot do biopsy, you still need to treat this patient. But of course, the bone biopsy is the gold standard, and we are going to make this happen. We are working, and we're already doing a bone biopsy for small number of patients, but our expectation was getting more people trained in this field. Will have more and more.
Dr. Amr, it seems that
I have
there
question.
is no a single lab test or marker can diagnose bone disease. You know, as the diagnosis of malnutrition in CKD patients, previously we depends on serum albumin, but at the moment we depends on many other investigation. I think this will be the same for the diagnosis of CKD-MBD. You know, in the past we depends on the IBTH, calcium and phosphorus. And with time, we know that there are many bone markers that you have already mentioned in your lecture, the bone resorption and the bone formation. And I think also there is a simple marker, as you said, the total, if we don't have the bone specific, the total IBH, the combination of total IBTH, the combination of total alka-phos, if we don't have the bone specific, with the IBTH, and in which direction they are going, we can diagnose is it a low bone turnover or a high bone turnover. I know that you are a bone biopsy fan, you know, you are, but we cannot proceed to bone biopsy in every case. I mean, the message for the young generation, we will not proceed for bone biopsy in spite of being a gold standard for diagnosis, but we cannot proceed for a bone biopsy for each patient. And this is, I think, was clarified clearly in the updated KD guideline, if it is going to change the line of therapy. This is my comments regarding Mustafa question. Can I ask you a few questions, Dr. Amr? I think we cannot let this a chance to go without asking a CKD-MBD expert like you. What about the assessment of serum vitamin D in CKD patients? Are you going, I mean, vitamin D3, are you doing this routinely? And if you find patients which is deficient to vitamin D3, what about the replacement? And did you study the effect of replacement of serum vitamin D on the IBTH and on the dose of active vitamin D? This is the first question.
Okay, thank you so much for your comments, Dr. Ala. As you pointed out, there is no magic test for CKD-MBD. It's a constellation. It's a panel of tests, including biomarkers, serum tests, including X-ray, and sometimes including bone biopsy, not for all patients, as you mentioned. I completely agree with that. For vitamin D, this is the most common question I am getting every single time in this meeting. Yeah, vitamin D, lower vitamin D level is associated with bad outcomes, but it doesn't necessarily mean that improving vitamin D level with the available vitamin D2 or vitamin D3 supplementation is going to improve the outcome. Actually, most of the RCTs didn't show, unfortunately, this happened. So if the patient, I would say, if the patient has severe vitamin D deficiency, of course, this can induce resistant hyperparathyroidism. So at least you need to control the severe vitamin D deficiency. But if the patient has, vitamin D of 20 or 30, yeah, I would like to use a non-pharmacological intervention like sun exposure. It's a very good source of vitamin D. Diet, which is another, very good source, especially seafood, salmon, tuna, fish, and also sardines, sesame seeds, legumes like ful, tamaya, it's a good source of vitamin D and calcium as well. Actually, non-animal protein sources are actually good source for both calcium and phosphorus as well, and to improve vitamin D level. Stop smoking, exercise. As we mentioned, especially in our dialysis patient, we need to get them active. Actually, some of the main caveats for this is the social and psychological status of the patient. Most of our patients, when they think that they have end-stage kidney disease, they are going to die and their quality of life is going downhill. So sometimes they are depressed, and it's not very uncommon. It's actually a common phenomena and the problem. So when they are depressed, they are inactive. They don't want to be actively participating in their management. So, getting them out of their couch and getting them actively participating not only in exercise program and physical therapy program, but in their management in general is very important. Adequate KT over V, adequate, I wouldn't say, I'm sorry, I wouldn't say KT over V. I know that there is a lot of fallacies, and so I would say adequate dialysis by all means is better. Home dialysis is better to control the CKD-MBD. All of these factors are very important.
Second question about the use of romosozumab. I think you, in your presentation, you pointed to a Japanese study. Can we have the details, if you don't mind? I mean, about the study, about the patient's number. Is it a randomized control? Because as far as I know, this anti-sclerostin has a black label binding. Is it? It has a black label list. It has an FDA warning, isn't it?
Yeah, very, very smart question. Again, Mamdouh may share the screen and show us the study. He's familiar with it. We discussed it a couple of times.
Okay.
So it's a very pragmatic study. Japanese people, it seems that the Japanese, globe is very advanced, and they are ahead of us several years. As you mentioned, there was a concern of using romosozumab, which is anti-sclerostin antibody, monoclonal antibody against sclerostin. So the problem with that, when you increase the bone formation, in the skeleton, there might be also a chance that this, when you inhibit sclerostin, which is a potent inhibitor of bone formation, with romosozumab, you might increase the calcification in the extra skeleton in the cardiovascular system. So there was a concern. I agree with that. But these people, as you see here, this is 1 year Japanese hemodialysis study among 96 patients who give 76 patients completed 1 year of sub-Q romosozumab every 4 weeks. And actually it showed safety and efficacy of using romosozumab. So it improved the spine and femur neck BMD, and hypocalcemia occurred, but without any intolerable event, and there was no apparent increase in cardiovascular events. They didn't do cardiovascular calcification study, but they did, the MAS, the major cardiovascular events study, and it didn't increase. We have criticism for this study because they might increase the cardiovascular calcification, and it might take time. Maybe in 2-3 years you'll see increased mortality. Again, this is the only study that we have for dialysis patients. So the safety is an issue here. If we are talking about CKD non-dialysis patients, there is other information, but these investigators were very brave to do this in dialysis patients. Agree.
Okay, thanks.
Dr. Magdi?
Yeah, Dr. Magdi.
Yeah, thank you. It's very interesting discussion. But I have a point of view, and I would like to ask Professor Amr and Professor Ala and everyone about how they feel treatment of CKD-MBD is usually is a failure up till now. We are not able to treat such patient properly. I think so. In my mind, because I have a lot of experience with this issue, is that we are starting very late to treat this patient. We have to start very early. And I would like to ask Professor Amr, in your practice, do you treat CKD-MBD in stage 2 or 3 CKD? Because this is the proper time to interfere and to treat this patient. After that, in stage 4 and 5, and all patients walking into dialysis, they have bad bones. And whatever you are doing, you are just delaying the progression, but you are not treating, you cannot treat them. So in my mind, we have to start very early. Stage 2 will be the proper stage to interfere. And I think it's not just the bone. It is the musculoskeletal system, because patients are usually losing their muscle power. It's not just their bone density or bone quality or quantity. They are losing their muscle power. And part of it is due to our, what we do in our patient. We prevent protein diet. We prevent exercise. We are very conservative in these patients, and they don't develop or maintain their muscle power. Most of our patients will be either sarcopenic or they have wasting. So what do you think about this issue?
Yeah, I agree with you 100%. So osteosarcopenia, we call it osteosarcopenia. If you lose bone, you lose muscle. If you lose muscle, you lose bone. So they go hand in hand together, absolutely. So the muscle part, you can see it, you can assess it, very easy. Even you can just measure the circumferential, of the patient arm or waist or whatever. So there is objectable assessment tools for the muscles. The problem was because the bone is the unseen part of this, so sometimes we forget about it. So yeah, I mean, bad nutrition is bad for both. Exercise, lack of exercise is bad for both. Definitely, if you have patient in the hospital who stayed in the hospital a couple of weeks, they lose muscles, they lose bone together very, very fast. Giving steroids, I mean, risk factors are almost the same. So it might be a good idea, as Dr. Magdi said, to do assessment of the muscle, because it's a very surrogate marker for the bone. They go hand in hand together. The other mentioned comment by Dr. Magdi Sharawi about late or early. Of course, the key is early. The problem, you asked me about our practice here. We have CKD clinics. I would say 90% of the patients here, at least, they don't show up with uremia from the beginning. They are followed up for years, sometimes for 10 years or so in our CKD clinic. Start with CKD 1 or 2 if they are diabetics. We start early or have some degree of proteinuria, we start early. But at least with a serum creatinine of 1.4 or 1.5, we start seeing this patient for years and prepare them for the renal replacement therapy. So the problem is not only controlling the CKD-MBD, but actually to start also the proper dialysis early and to do adequate dialysis, very, very important. And to start with a good residual kidney function, because if you wait too long and the patient lost his residual kidney function, it's very hard to do, for example, peritoneal dialysis with a patient without, residual kidney function. Most of the CKD-MBD abnormality and other, anemia in CKD, acidosis in CKD, and other metabolic complication and consequences of CKD happens if you start late. Or when I see young patient in Egypt who are presenting for the first time in the emergency room or to a doctor with uremia, with a creatinine of 15 or 20 or something like that. Of course, by that time, as Dr. Magdi said, they already lost quite a bit amount of their bone, their muscle, their cardiovascular calcification is huge. They have multi-organ failure, cardiomyopathy, volume overload, their lung is wet. I mean, there is a lot of other complication, and sometimes it's actually, very late to, prevent or to reverse this problem. These problems are very difficult to reverse. The bone loss, the muscle loss, the cardiomyopathy that can happen in this patient, the resistant hyperbara that can change from secondary to tertiary hyperbara. All of these, sometimes if you start late, you are just wasting your efforts, wasting money, because the patient is not going to respond. So early detection, early diagnosis is very, very important.
I totally agree with you, Professor Amr. And also, even if the patient is prepared for transplantation, he should take care of his bone, especially in preemptive transplantation. This is another important issue.
Absolutely. We all miss the bone after transplantation. Doing kidney transplantation is not going to solve the bone problem. Actually, it can worsen it. So you have to be also vigilant and careful about post-transplant bone disease.
Prof. Magdi, do we have any future project for our Egyptian fracs?
Regarding CKD-MBD?
The fracs as a whole, fracs. We don't have in Egypt fracs score for Egypt. And we depend on other Arabic countries. Do we have a plan for that?
For what? For what? I need...
For fracs score.
So fracture score, Dr. Magdi, is the fracture assessment.
It is done individually. It's not done as a systemic, in systemic way. In Egypt, we are nephrologists. We don't work with orthopedics. We don't, if they have a broken bone in a CKD patient, they just tell us how to dialyze him. They don't ask about the treatment of this fracture regarding its metabolic effect or its kidney metabolic effect. So I don't think we have it. We have some studies about the fracture rate, and especially in post-transplant patients, but not in dialysis patients. And as Professor Amr mentioned, most patients in Egypt start dialysis either late or very late. So their bone is not good. And when they've got fracture, usually they are referred from centers that don't have a facility to treat this patient to another centers. So the follow-up is not there. I don't know what's the condition in Mansoura. Professor Ala can enlighten us.
Professor Magdi and Dr. Mustafa, I think the problem is not in the presence of guidelines. I mean the national guidelines. We should have the national guidelines, which will be a little bit different from the international one. But I think the main problem is the interpretation of and the implication of this guidelines, and second, the collaboration between different physicians. As Mahmoud Sobh presented his case, you know, the case showed us that there is no cooperation between the physician, I mean the nephrologist, and the surgeon as well. And we are confronted with many cases like this, you know, whenever we send a patient to just to insert a BD cast, maybe the surgeon can see the case just in the operative theater. There is no good collaboration between us. It's not a problem of having a FRAX assessment. It is a problem of applying the FRAX score. I think we can cross over this, and we can manage this by a cooperation between different centers. You know, here from Mansoura, Ain Shams, Qasr Al-Aini, we can have a collaborative work as well. You know. My second question to Professor Amr, what about I think in the future we will have many fortunes. You know, we will have many synthetic IPTH. What about is there any difference between the teriparatide and the abaloparatide? I mean, between the synthetic IPTH and the IPTH-RB? Is there any difference in the mechanisms that will impact the side effect in the future?
Thank you, Dr. Ala. Of course, this was studied in patients without CKD or with mild CKD. So there is post hoc analysis comparing abaloparatide to teriparatide and mild to moderate forms of CKD as well. On top of the general populations of both the post-menopausal osteoporotic woman, and both in non-CKD and mild to moderate CKD, of course not including dialysis, these post-hoc analysis showed safety and efficacy and superiority of abaloparatide compared to teriparatide. So it seems abaloparatide can improve the BMD much faster, and with the percentage change of the total BMD scores in the vertebrae and in the hips was better compared to the teriparatide. Again, when we are talking about end-stage kidney disease patients, there is no RCTs comparing teriparatide to abaloparatide. There is only small studies that showed efficacy and safety of abaloparatide, but it wasn't compared with the teriparatide.
Okay.
If we have one more comment or one more question to close today's sessions.
We have question in the chat. When should
just one, because we are already 16 minutes behind.
Okay, last one. When should we refer to a surgery in tertiary hyperparathyroidism after treatment with calcium mimetic? You ask about the duration. So the duration of medical treatment before you consider it like a failure.
Okay, yeah, duration is should be accounted, but it's not only the duration. If you start late, you're not going to get a good response. If the BTH is 500, 600, 700, Up to 800, that's okay. You can control it medically. I don't have problem with this. Just make sure to give good dose of combination of vitamin D analogs and calcium mimetic. With good dose of calcium mimetic, sometimes we go up to 90 milligrams twice. I know that there is, financial consequences with that, but anyway, sometimes we give up to 180 milligrams of cinacalcet. Sometimes you need to switch from the oral cinacalcet to the eticalcetide, it's called here Barcipev, which is injection. We give it on dialysis at least to improve compliance. The GI side effects is almost the same. Actually, when they started working on this medication, they thought it will improve the GI problem that can induce by cinacalcet, but actually the side effects, the GI adverse events are both the same. But in severe cases of hyperbara, and I would say with a BTH of 1200, 800 to 1200, it's more effective. It can lower down the BTH up to 50%. So if you start with 1,000, you can bring it down to 500. But the case that Mahmoud presented was a BTH of 2,000. Don't waste your time, your resources. This patient is not going, if it is persistent BTH over 2,000, it's very, very hard to control it medically. It's okay to do gentle parathyroidectomy. Talk to your surgeon. Don't tell him that we are targeting BTH 150 to 300. That's fine. Even failure of parathyroidectomy is better than ending up with severe hypoparathyroidism and hypocalcemia and adynamic bone disease. I think we can stop by today here. I think we shared a lot of information, and me myself has learned a lot from the lecture and discussion and the case presentation. Tomorrow, inshallah, we're going to start at 4, and hopefully we can finish at 6:30 as well. We have some about 20 minutes delay today, so hopefully we can finish at time tomorrow. Thank you, everyone, and tomorrow we will have great presentation, case discussion, so try to stick around and learn and share your experience and ideas. Thank you, everyone.
Thank you much.
See you tomorrow.
See you
Very
tomorrow,
much,
inshallah.
Dr. Ala, everyone.
Bye.